Congratulations, Ron, David, Henry, Maurice, for outstanding symposium. I've really enjoyed the last few days. I've enjoyed learning from all these great speakers, and I'm happy to be part of this great symposium. Also, Happy Lunar New Year for our colleagues from Asia. Now, what I'd like to share with you is the decision-making process that goes around the time of transitioning teeth to implants. And the decisions that are made, sometimes that are not appropriate, in this case, placing implants inappropriately in a situation where it wasn't indicated and in using incorrect protocol. And also the decisions to inappropriately extract teeth and do nothing about that and allowing the site to resorb. So these are two inappropriate decisions. So what I'd like to do is to talk to you about some of the thought process that goes into the decision-making process around the type of making the decision when to extract hopeless teeth and transition them to dental implants. So as a clinician, I have a number of questions. And I like to pose these questions and try to find scientific evidence to support our philosophy and our protocol for today. So the first case, which will illustrate some of the principles, is a gentleman who is about to lose the two central incisors because of fracture. So after the clinical examination, and we determined the presence of the facial plate by examining the cone beam CT data, especially by doing this type of digital virtual planning. And as you can see that the facial plate is intact in this case, so we'll go ahead and consider immediate placement. This is what Dennis called this morning type 1 type of defect, where extraction socket has intact bone and intact soft tissue. So we can go ahead and place our virtual implant and determine the optimum position for those implants, and I'll describe what those optimum position is and why. So the first challenge is to make sure that we extract the teeth using as little trauma as possible. And of course, you could use a freehanding technique as Dennis described today, or we could utilize some of the devices that are available to try to remove the teeth with as little trauma to the facial plate as possible, as was done in this case. So the goal is to try to preserve the facial plate if it's already there. Now the challenge is to try to position the implants in a proper, precise position as possible, and one can either utilize the freehanding, or we could utilize the technology of stereolithographic drill guides to precisely position the implant. We can perform our osteotomy and place the implant through the drill guide. But what are the precise positions? Because these drill guides have no prosthetic landmarks and do not allow us to make any adjustments. So it's very important that we make all of the positioning plans in our planning software. So is the position of the implant important? And Dennis today explained the importance of placing implants more to the palatal. And this has been supported by a great deal of evidence that when implants are placed too far facially, there is going to be recession, especially when we have thin biotype. There's the work of Mariano Sanz and his colleagues in Madrid, Spain, and they've done a lot of great work in the area of immediate placement. And this particular study that was published in 2010, they determined that when the implants are placed too close to the facial plate, if they're placed within a millimeter of the facial plate, there's going to be more bone loss. So what they found is that the further you place the implants away from the facial plate, the more bone gain they observe. So implants need to be placed as far to the palatal or lingual as possible. Now, how many of you have been told that we're placing implant using prosthetically driven planning? In my view, the only people who refer to it as prosthetically planned implants are periodontists who are really kissing up to their prosthodontist colleagues. Because, as you could see, it's really biologically driven. Because the biology will dictate where the implant should be placed. The implant should be placed toward the palatal or lingual, because when you place it too far facially, there's going to be more bone loss. However, we're not going to ignore the prosthetic concern, because there are also prosthetic feedback into the process. Because if you place the implants too far to the lingual palatal, we're going to have inappropriate prosthetic contours, as you could see in this case. So we have to reach a compromise between what biology will tell us and what the prosthetic determinants are. In this case, we'll merge the two and give you some guidelines that will both satisfy the prosthetic as well as biological issues. So what should be our proper position? Well, we consider first the vertical depth of placement as well as horizontal positioning of the implant. So if we're looking at the two teeth before the extraction from an occlusal view, we can see the height of contour of the teeth, and we can also consider what the cervical contour of those teeth are. And if you were to extract those teeth, the height of the cervical contour is the rim of soft tissue around the socket. So when it comes to the positioning in a vertical direction, you want to place the implant. In a horizontal direction, you want to place the implant 2 millimeters to the palatal of that facial plate. So 2 millimeters to the palatal, and this will be appropriate because it's more than a millimeter, as was determined from the biological factor, and also it will be in a position where the restorative dentist will be able to provide us with the proper emergence profile. In a vertical direction, you want the implant 3 millimeters above the zenith of mucosa, and that will be because it will allow the establishment of proper biologic width in this area. So then, if we can review that, 3 millimeters in a vertical direction to allow the establishment of a biologic width, and 2 millimeters in a palatal direction so that we're sufficiently away from the facial plate, more than a millimeter away from the facial plate, but also in a position that will allow proper emergence profile. Now, there has been significant information about the biologic width and the dimension of that, and we can see some of the studies that have been done with CBCT that determine that the position of the crest of bone relative to the CEJ can vary depending on the tooth. However, for the most part, it's around 3 millimeters. So that will be the reason why we place the implant about 3 millimeters in an apical direction. So once we place the implants in this position, we're going to place our abutments and now fabricate the provisional restoration. When the provisionals are placed, it's important to make the provisionals with slightly under contour to allow the tissue to fill in those spaces. You don't want to have the proper contour yet. You want to allow the tissue to grow in there, and later, when it's time for the final restoration, the restorative dentist can rebuild the proper contour. So at this point, you want the contours to be flat or just slightly convex. You want as much space in the embrasure space just to support the papillae without compressing them at this point, because we want the soft tissue to grow in there so that we have adequate soft tissue, and later with the proper contour, we'll be able to establish the proper emergence profile in the contour. And as you can see, once we respect these principles, the bone is going to remain stable for us, as this case is already 6 years out. And you can see the stability of the soft tissue and the stability of bone around the area. Now, when these principles are not respected, as in this case, where the implant was placed very deeply, this is what happens. Cement that becomes almost impossible to clean, and a great deal of inflammation. So in this case, the implant was placed 10 millimeters below the mucosal margin. Now, this morning, Dennis described the importance of the facial plate and made you all to pledge that you don't place the implant if there's no facial plate. Let's examine the scientific reason why the facial plate may be important. Well, there have been studies by Professor Lindy's group which have determined that if you surgically remove the facial plate in this canine model, there's going to be bone fill on all aspects except on the area that has a dehiscence. The area that has a dehiscence will heal with more soft tissue than bone. It will not fill in properly. There's also studies that have been published by Joseph Kahn, which describe that in those cases where there was defects, the dehiscence defect, despite the augmentation, and these are images from his publication, there's going to be a significant amount of recession that takes place. So there's also studies from Pascal Valentini, which describe more failures with, in cases that had facial dehiscence. And as I said, Joseph Kahn's study showed high incidence of recession when there was a facial dehiscence, fewer sites with bone fill, and greater horizontal resorption in those cases that have facial dehiscence. So in my view, there's sufficient evidence to suggest that the outcome of cases that have facial dehiscence to begin with is poor. So it's not a proper case for immediate placement. And I know many clinicians prefer to place the implant immediately and do the simultaneous augmentation. And I concur with Dennis's recommendation of not placing the implant if there's a facial dehiscence. So what do? Dennis Sarna described the technique of ice cream cone, and we can utilize that in these cases where there's a facial dehiscence. As we observe in this case, after extraction, there's an 8 millimeter dehiscence. So we could place a collagen membrane and fill the socket with xenograft in this case. And in this case, we performed a soft tissue plug over the area, a socket seal technique described by Kobe Landsberg, and then allow the site to heal, in this case, for about 6 months. And as you can see, that there's adequate ridge contour to allow placement of the implant at this point. So in this particular case, the implant was placed. Yes, there is some horizontal shrinkage, but there is adequate bone for placement of the implant. And once the restoration is placed, in this case, the implantus abutment, it allowed the tissue to be better supported so that we can go from the pre-op situation to the final restoration and have very little changes in the soft tissue contour. And this is after 2 years. Now, so we know that the presence of the facial plate is very important. What about the quantity of the facial plate? Does it matter how thick that facial plate is? Well, the facial plate has been measured in many different ways. In this particular study, using clinical examination, direct measurement. It's also been measured by several studies by cone beam CT, some cadaver studies. But basically, most of these studies have found out that the facial plate is thin. They found in this particular case, in this study, that about 40% of the site have facial plate that's only 0.5 millimeter. Another 30% are 1 millimeter. So we can see that in about 70% of cases, the facial plate is 1 millimeter or thinner. And is it important? Is it important how thick that facial plate is? And the studies from Mariano Sanz's group, the Ferrous paper, demonstrated that yes, sockets that had facial plate that was less than a millimeter had more bone resorption. In those cases that had thin facial plate, those experienced a great deal of bone resorption. So not only the presence of it is important, the thickness of the facial plate is also important. So as you can see here, 70% of the cases have a millimeter or less. So we know that in 70% of our cases, we're going to have some degree of bone resorption as a result of that facial plate being a millimeter or less. And even many have suggested that the facial plate should be 2 millimeters or more. But look at how many cases have 2 millimeters or more. Very few cases. Only 95% of cases are less than 2 millimeters. So if you're only going to place immediate implants in those cases that are 2 millimeters or more, you'll never place immediate implants. So what are the other aspects? Now that we've established the anatomical parameters, what should we select as our implants for these sites? Should we use wide diameter implants, or should we go with narrower diameter implants? Well, there have been several studies that have demonstrated that wide diameter implants exhibit more bone loss. There's histological evidence, there's clinical evidence, and many of us found the hard way that wide implants are associated with more bone loss. And so it's important to then make the recommendation now to use narrower diameter implants. So what about the placement of the implant into the socket? Is that going to prevent resorption of the bone? Many of us will tell our patients, you better have this implant placed today or you're going to lose the bone. Are we being truthful to our patients? Well, studies from Araujo demonstrated that immediate placement does not prevent bone resorption of the socket. In fact, the facial plate undergoes about 56% resorption. The palatal plate is a little bit more robust, only 30% resorption. So what is the difference between the facial plate and the palatal plate? I'll explain in a minute. So here's one of my cases in 2004. I performed extraction, immediate implant placement. Here's the same person in 2011 without any form of augmentation. As we can see, there's a significant amount of horizontal resorption that took place in this 7-year span. But when we examine the CBCT images, we could see that the bone did not disappear from the implant. The implant does have a thin layer of bone on the facial aspect. So the implant does retain the bone. So let's just examine this a little bit more closely. You see, when we place the implants, and Judd Davis has described 2 forms of healing in extraction socket. One that he refers to as contact osteogenesis is the new or de novo bone formation directly on top of our implants. And for this form of bone formation, the surface of the implant is very important. And then we have the bone that's forming from the parent bone that's called distant osteogenesis. So you have contact osteogenesis and distant osteogenesis. And you can see that if you have the contact osteogenesis, you always have bone on the implant. But then the distant osteogenesis could be debatable because it will form on the existing bone, and whether or not that existing bone actually remains, that's been demonstrated by many that it does not, because that bone is made out of bundle bone. So when we're looking at this histologically, as Jan Lindy has demonstrated in many of his publications, if we're looking at the histological images of the tooth, PDL, and bone, we can see that the alveolar bone that directly abuts the PDL, is permeated by the fibers of the Sharpey's fibers. So that bone that's permeated by Sharpey's fiber is called bundle bone. Bundle bone is not part of the, it really belongs to the tooth. So once you extract the tooth, that bundle bone is going to resorb, no matter what we do. Whether we place an immediate implant, whether we do socket grafting, that bundle bone will resorb. Now, the quantity of the bundle bone has been estimated to be around 400 micron, close to 0.5 millimeter. So you can imagine in those cases where you have very thin facial plate, most of it is made out of bundle bone. That's the reason that the facial plate is so susceptible to resorption, and the lingual or palatal plate, or the bone that's thicker, is less susceptible, because in addition to the bundle bone, which is called alveolar bone proper, there is also structural support from the alveolar bone and will maintain the bone in the area. So does it help if we place graft material within that gap? Dennis and Steve Chu today described the importance of grafting that area, and their clinical experience and the clinical studies clearly demonstrate the importance of that. There's also been histological evidence from Araujo and Lindy, which demonstrated in this dog study that the sites that had graft placed in the interface between the implant and the socket had maintained the thickness of the facial plate better, and also vertically, the crest of the bone maintained its height better and was consistently positioned in a more coronal location. So we're going to graft that. Now, what I like to use is a xenograft, which we know will not resorb for the most part. Most of it will remain in the site. And that's going to maintain the architecture and geometry of the socket better for us. So what I like to use is a large particle size. We did some studies, histological studies, that demonstrated that large particle size, because it has more porosity, actually associated with more volume of vital bone formation. So I like to use the large particle size, which is 1 to 2 millimeters. You can imagine that if you place the graft after you place the implant, it would be very difficult. So what I like to do is, after performing the osteotomy, place the graft only in the area that is going to be occupied by the facial plate, the gap between the implant and the socket. And I could just place either a drill or something to prevent that from occupying the portion that's going to be occupied by the implant. And then we can go ahead and place the implant afterward, and that way we're sure that we can place the implant, the graft, all around the facial aspect. And once the implant goes in, of course in a more palatal direction, that gap is going to be occupied by a graft material. And then once we place the abutment and then the final or the provisional restoration, by that time the tissue will contract a little bit and will cover the graft material. And that's how the patient goes home under the grafting. So I think we're beginning to see the value of the grafting from the clinical and experimental evidence. What about the soft tissue? Is the biotype important? We hear a lot from clinicians with experience who will tell us that biotype is very important, but is there actual evidence that biotype is important? And the studies from Evans and Chan have demonstrated the importance of biotype, especially if implants are placed too far to the facial. And Joseph Kahn has reminded us that biotype is more important for the facial remodeling, not so much for the interproximal remodeling of the soft tissue. So it's more important for the facial aspect. However, for the sake of completeness, I have to describe that there have been publications which have not found the significance of biotype. And in my interpretation is that if you place the implants palatally enough, the biotype is not as important. If you place the implants facially, it can bail you out if you have thick biotype. There's also experimental evidence that biotype is important for platform switching implants. If you have a thick biotype, platform switching implants can minimize bone resorption. Whereas if you have thin biotype, platform switching doesn't work. So platform switching only works if you have a minimum thickness of the mucosa over the area. Now, does it help if we graft the area? Yes. There is experimental evidence from this canine study that performing a connective tissue graft does increase the mucosal thickness and also maintains the tissue at a more coronal location. Now, there have been many techniques of soft tissue grafting, and Pat Allen very elegantly described his technique of intracellular tunneling and placement of allograft for soft tissue augmentation. I will also show you my take of how I perform the soft tissue augmentation, especially in these cases of immediate placement. This is a patient who had very thin facial plate, and he happens to be an attorney, so we are a little bit more extra cautious. So we have to be very careful in extracting the tooth, and we use all the tools that we can to try to remove it with as little trauma as possible. Now, instead of making a flap to place the implant, we're going to utilize the VISTA technique. VISTA stands for vestibular incision, subperiosteal tunnel access. So we make an incision in the vestibule, and that is the basis of our access. When I try to go through the intracellular tunnel, it's difficult for me. So I'm lazy. I like to take an easy way out. I like to make an incision in the vestibule and take a vestibular approach to that and make a subperiosteal tunnel, which makes it very easy to access the facial plate. But at the same time, we have not made any incision in the marginal mucosa or the papillae. So we've spared that area. But the benefit of this VISTA access is that we have the ability to evaluate the facial plate during the positioning of the implant to make sure that the facial plate is intact. If we need to graft the area, in this case there was a periapical lesion, we needed to graft that, we can address that. So we can position the implant and have direct view through the VISTA vestibular tunnel, and the implant is positioned palatally as we should be placing that. And then, in this case, I harvested soft tissue from the tuberosity, which is more dense, fibrotic, deepithelialized, butterflied like a sashimi, and then place it through the VISTA tunnel, which is very, very simple. You can place a very thick graft, and it only adds a few minutes to the procedure. So we can routinely graft these sites to try to compensate for some of the soft tissue resorption that would take place, and especially when we use the thick tissue from the tuberosity, that density is maintained. So we go ahead and fabricate the provisional restoration in an under-contour form, and you can see that there has been no incisions in the marginal mucosa or the papillae, and we'll send the patient home with a cement-retained provisional restoration. This is the healing of the soft tissue. As you can see, that the patient had already experienced recession in adjacent teeth, and we wanted to avoid having similar type of recession or mucosal of remodeling during the healing process. So then we follow up, convert the patient from the prefab abutment to a CAD/CAM abutment, so we have a more uniform margin and we support the tissue better. And we go to the final restoration. You can see that the soft tissue contour is maintained, both in a vertical and horizontal direction, and this case is already 3 years out. So what I like to do is to try to summarize that in the last 40 seconds that I have to talk about what do we know about the biological concepts. Let's look at our interface very closely. As I mentioned, that the facial plate is made out of about close to 0.5 millimeter of bundle bone, 400 micron of bundle bone. And we know that this bundle bone is going to resorb. So if you have a thin facial plate, most of it is going to be bundle bone. And no matter what we do, that bundle bone is going to resorb. Now, if you have a thick facial plate, some of it will remain, such as on the palatal side. Now, when we place our implants, if we place it sufficiently to the palatal, how is the bone going to form on there? Through contact osteogenesis. Contact osteogenesis will assure that new bone will form on there. So it's important that we utilize an implant surface that will promote that contact osteogenesis. Now, how about grafting? Yes, by placing the graft in an interface, we can support the tissue better, provide a scaffold to allow more bone to form through distant osteogenesis and not allow the tissue to collapse there. How about if we place the implant to the facial? When you place the implant to the facial, the soft tissue is going to fill in that gap before that contact osteogenesis has an opportunity to take place. So we end up with discrepancy and shortage. So we end up with several threads that have a dehiscence. With that, I hope this information has been helpful to you. I appreciate the opportunity to participate, and thank you for your attention.